I'm really excited to pivot us to this next session. I think that this has been a really transformative year in the Duchenne landscape. And when I really take a moment and step back, I think about how this world looked when I first entered the Duchenne world, and there were no approved therapies, not a single one. And it looks a lot different now. Now we have 8 approved therapies, and that is really, really remarkable. I'm so incredibly excited about this. But with all of these new approved therapies comes a lot of questions in how we navigate these drugs, when do we prescribe them, who are the right patients, how do we navigate this ever-evolving and really complex landscape. I think what's even more remarkable is that over the last year alone, we have 3 new approved therapies. We have these new drugs in Agamree, Duvyzat, and Elevidys, first with its initial approval and then expanded label. And so I think that, today we're going to take some time and we're really going to explore these 3 newest therapies, understand sort of what the drugs are, how they work, who the target patient is, and really navigate sort of those nuances before we pivot into a conversation to dig further into decision-making, how to advocate for yourself or for your family as you think about which drugs are most appropriate, and how to have a conversation with your medical team about what makes the most sense for you and for your family. So with that, I'm going to invite up representatives from across the industry right now, specific to these 3 most recently approved therapies. We have Serene Nelson from Catalyst, who's going to present on Agamree. We have Scott Baver from ITF, who's going to talk to us about Duvyzat. And then from UC Davis, we have Dr. Craig McDonald, who's going to provide an overview on the recently expanded label for Elevidys. So at this time, I'll invite the 3 of you to come and join me on stage. Serene from Catalyst is going to start us off with an overview of Agamree, also known as vamorolone, and we're really eager to hear a bit more about this product and understand, some of the nuance and how to navigate this brand new world.
Thank you. Are they going to? Okay. So I'll just start by introducing myself. Hello, I'm Serene. I'm the Neuromuscular Medical Science Liaison with Catalyst Pharmaceuticals for the Northwest. So I come to you today from Gig Harbor, Washington, much different weather than what we're having there. So thank you so much. It's an honor to be with you today. So are they pulling up the slides? There we go. Okay, so today I'd like to talk to you about Agamree. We're going to have some information about this. Let's see if I can forward this. There we go. Okay, so our mission is to build and sustain trusting relationships with families and advocacy organizations to address this rare disease issues. And we want to we know there's been a lot of interest in getting Agamree to the market, and there's been a lot of work done by individuals and families and advocacy organizations, so we want to thank you all in helping get Agamree available to the ones who may benefit from it. So thank you very much. So first, I'd like to do an overview of Agamree, including indication, dosing, key clinical trial data from our Vision DMD trial, and registry information. Then I'd like to spend a few minutes talking about the Catalyst Pathways program. So Agamree is a new corticosteroid for the treatment of Duchenne muscular dystrophy in patients 2 years of age and older. So just a little important safety information to note is that you don't want to take it if you're allergic to vamorolone or any of the ingredients in the product. Let's start by talking about how Agamree works. So we know that traditional corticosteroids are effective in maintaining muscle strength and function and delaying disease progression. However, they still have many unwanted side effects, such as effects on height, effects on bone and fractures, and also weight gain. So they were looking for a new corticosteroid who could still have this anti-inflammatory effects while decreasing some of that unwanted side effects that we don't want to see. So Agamree is a new and novel corticosteroid that does this. It has still that potent anti-inflammatory activity while potentially decreasing some of those undesirable side effects. So when you think about what's happening to Duchenne, inflammation is one of the main factors causing that muscle damage. And that inflammation is caused by NF-kappa B mediated pathways. So that's what causes some of this inflammation that causes that muscle damage. So Agamree works by limiting or inhibiting that NF-kappa B mediated pathway to decrease that inflammation. So that is similar to all the traditional corticosteroids. However, the molecular structure of Agamree is different. So it binds differently to that glucocorticoid receptor, so hopefully decreasing some of those side effects that we don't want to see. So it still has that potent anti-inflammatory activity while potentially decreasing some of those unwanted side effects. So Agamree is an orange-flavored oral suspension taken once a day and preferably with a meal because that's how it was studied. So when you get your bottle, it is a suspension, so you want to shake it really well, and then you want to withdraw the correct amount, dosed in milliliters, into the provided oral syringe. Then that's just administered directly into the mouth. And then once you've opened the bottle, it needs to be refrigerated for stability, and it's good for 90 days in the refrigerator. So if there's anything left in the bottle after 90 days, you want to discard that. Also, it's important to check your dose in milliliters, and it's dosed as 6 milligram per kilogram to a maximum of 300 milligrams per day in people weighing more than 50 kilos. So now I want to talk to you briefly about one of the pivotal trials, the Vision DMD trial for boys living with Duchenne. So Agamree was studied in a 24-week trial in 121 boys with Duchenne's between the ages of 4 to less than 7. And these boys had not previously or they weren't currently on corticosteroid treatment. So the treatment was broken down into 4 different arms or treatment groups. So there was the placebo or the sugar pill group. There was the prednisone 0.75 milligram per kilogram per day group, and then 2 groups of Agamree, the 2 milligram per kilogram and the 6 milligram per kilogram group. And they looked at the effects of Agamree on muscle strength and function compared to placebo or that sugar pill. So there are 3 endpoints I want to look at from this trial. So the primary endpoint was the time to stand velocity, and this measures the time it takes for the patients to rise from a lying down position to a completely upright position. So this was the time to stand speed or velocity is what this trial looked at. So for the Agamree 6 milligram per kilogram dose, they found that the velocity or the speed was 0.06 rises per second faster than placebo. And for the lower Agamree dose, the 2 milligram dose, it was 0.45 rises per second faster than placebo. So this is important because for this motor endpoint, the clinically important change is 0.2 rises per second. So both of these doses meant that clinically important change. But even more importantly, the difference of 0.05 rises per second is thought to delay the loss of ambulation by 2 to 3 years. The second endpoint that I want to look at is the 6-minute walk test. And this measures the distance a patient can walk on a flat, hard surface in a period of 6 minutes. So again, Agamree, the 6 milligram per kilogram dose, the boys were able to walk 42 meters farther, and for the lower Agamree dose, they were able to walk 40 meters farther. And for this motor endpoint, the clinically important change was greater than 28 to 32 meters. So both of those doses met this clinically important difference. And the third endpoint I want to talk to you about is the time to run, walk 10 meters speed. So kind of self-explanatory. It measures the time it takes for a patient to walk or run 10 meters. So the clinically important change in this one was greater than 0.2 meters per second. And for Agamree 6 milligram per kilogram dose, they were able to have a speed of 0.24 meters per second faster. So it meant that clinically important change. Now let's talk about some of the side effects in the trial of Agamree. So these were the side effects on this chart that occurred in at least 5% of the patients treated with Agamree and more frequently than placebo. So you see some of the top ones for the highest dose of Agamree were cushingoid features, psychiatric disorders, and vomiting. Now I'd like to talk about, remember one of the treatment arms in this study was the prednisone group. So let's look at how Agamree treatment compared to those in the prednisone group on certain safety measures. So one of those safety measures was growth. So they found that after the 24 weeks of this trial, the boys treated with Agamree in both the 2 and the 6 milligram per kilogram per day had an increase in height projectile compared to the boys that were on the prednisone arm. They had a decrease in growth projectile. So that was one of the changes they found in comparison. Also, they looked at biological markers, which they looked at bone health. So Agamree treatment was not associated with a reduction in these biological bone markers, whereas in the prednisone group, there was a marked reduction in these biological bone markers. The third thing they looked at was behavior problems. So the Agamree treatment was associated with less behavior problems compared to the prednisone group in this 24-week trial. So fewer boys treated with the Agamree 2 and 6 milligram per day had shift from normal to abnormal behavior in the categories of dependency, hostility, and productivity compared with prednisone. And this was based on the PARS-3 scale. And that looks at starting at normal behavior and going to abnormal behavior. And there's 28 questions in that PARS-3 scale. So what are some important safety information you should know about Agamree? First of all, like with all corticosteroids, there is an increased risk of infection. Corticosteroids like Agamree can cause increase in blood pressure and water retention. Corticosteroids like Agamree can cause severe behavioral and mood changes. And there is a risk of developing osteoporosis with any corticosteroid like Agamree. Corticosteroids like Agamree can also cause cataracts or glaucoma, and there have been rare instances of severe allergic reactions with corticosteroids. So before starting Agamree, you want to tell your healthcare provider about any medical conditions you may have, including if you have decreased liver function. If you do have decreased liver function, you may have to have a reduced dose of Agamree. Also, you want to tell your healthcare provider about any medication you take, including prescription, over-the-counter, herbal, or dietary supplements. And there may be some drugs that have a drug-drug interaction with Agamree, so it's important to tell your healthcare provider all that information. So a few other things you should know about Agamree. The one thing is important is that if you need an immunization, you want to make sure that all of those are up to date before you start taking Agamree. Especially if you need live vaccines or live attenuated, it's really important those start at least 4 to 6 weeks before you were to start a corticosteroid treatment like Agamree. Also, Agamree is an adrenal suppressant like the other corticosteroids, so this is really important that once you start taking it, you don't want to stop it or reduce the dose without talking to your healthcare provider, because you want to gradually decrease the dose to risk the possibility of adrenal insufficiency crisis, which can be fatal. So, of course, we want to avoid that at all costs. And some exciting news is that Catalyst is establishing a real-world registry called the SUMMIT Study to better document long-term effects of Agamree. So the SUMMIT registry will have 25 trial sites in the United States for patients to enroll. So if you're interested in enrolling this or need more information, please come talk to us. We're very excited about that. If you want some more prescribing information about Agamree, you can scan the QR code or visit the URL here. Now I'd like to spend a few minutes talking about the Catalyst Pathways program. I have about 2.5 minutes, so I'll have to go a little quickly through this. So first of all, our Catalyst Pathways program is a robust patient support program that can provide people with rare disease and their families one-on-one support through their treatment journey. We have a dedicated team of professionals that can help you with issues like starting treatment, questions about your medication, or the all-important insurance issues. So we have care coordinators who are your first point of contact, and they can provide you with the catalyst pathways, explain it to you, and get you on track. We also have the PALs, or the patient access liaisons, who will also assist you in this process. We have other support services, such as resources for non-English speaking people. We have interpreters that we can use, and we also are developing a lot more of our Spanish materials, or materials written in Spanish, to help those people who are non-English speaking. There's also a delivery assistance program to make sure that your crucial medication is always available when needed. And there's a bridge program that can provide free medication to you while you're waiting for issues like insurance authorization. And if you need more support with financial issues, there are resources available to help guide you to some of those available financial resources, such as out-of-pocket costs and insurance issues. To access Agamree, you want to start by completing a pathways form, enrollment form. So we are currently accepting these forms, but the best way to access Agamree is to ask your prescribing physician to complete this enrollment form and then return it to Catalyst Pathways. Once the enrollment form is sent to Catalyst Pathways, we'll work with your insurance company to make sure that your medication is covered. And once the medication is approved, the care coordinator will reach out to you, welcome you to the Catalyst Pathways, and give you a welcome brochure that has a lot of information in it for you. And then care coordinator will also reach out and let you know when your shipment will be delivered to you. And we have a specialty pharmacy called Anova RX that delivers that right to your door. So Anova RX is our specialty pharmacy. Like I said, they mail it right to your door. You can't get Agamree at your retail pharmacy, so this has to go through Anova RX. And they will deliver to you as quickly as possible and even overnight it to you if needed. And a nice benefit about Anova RX is they have pharmacists available around the clock by phone to help you if you have any medication questions. And this is their number here, 1-844-288-5007. Thank you very much for your time today, and I hope this information was useful. We do have a booth, so if you have any further questions, please stop by and they can help you with that. Thank you so much.
Thank you so much, Serene. That was a really helpful overview of Agamree, and we're just going to keep rolling through the session. I'm going to invite up my new friend Scott from ITF, who apparently likes to do multiplication tables in his head to, have fun. So let's go.
Thank you. Thank you very much. Can everyone hear me? Great. It's a little tough to hear over on that seat. So I want to thank all of you for giving us the opportunity on behalf of everyone here at ITF and Atala Pharmaco. I also want to take a little bit of time and recognize how much of an important time this is for the community with recent approvals of folks who are sitting here on stage, recent expansions, and we're really happy to come and introduce Duvyzat to you today. So for today's talk, I'm going to break it up into 3 specific topics. First, I'm going to walk through how we think givinostat works in Duchenne. And then we're going to walk through some of the key data from our phase 3 Elevidys study that was responsible for the approval of Duvyzat here in the US. And then finally, I'm excited to introduce our patient access program that we have, which is entitled ITF ARC. First, I do want to state that Duvyzat is an HDAC inhibitor. It's indicated for the treatment of Duchenne muscular dystrophy in individuals who are 6 years of age or older, and this is for regardless of genetic mutation. So let's start with how we think givinostat works. So we all know that the lack of functional dystrophin results in muscle damage, but we also know that the lack of functional dystrophin also can result in inflammation. It can result in fatty deposits as well as scarring, and more importantly, it results in impaired repair mechanisms from the muscle damage. So important for us at ITF Therapeutics is that there is an enzyme protein that is also overactive and may play a role in each one of these particular processes: the inflammation, the scarring, the fatty tissue deposit, and again, the impaired repair mechanisms for muscle regeneration. So what we think and we asked is, if we add a drug which is an HDAC inhibitor, or histone deacetylase inhibitor, can we restore the downstream effects without having functional dystrophin as part of the process? And so what we've seen in preliminary studies, so if we think about animal models or even early clinical studies, what we've shown is there is an actual decrease in inflammation, in fatty tissue, a decrease in fatty tissue deposit, a decrease in scarring, and then a potential improvement in the repair mechanisms leading to muscle regeneration. And that happens after the administration of the histone deacetylase inhibitor, givinostat. What does that mean functionally? We needed to test that in a clinical study. So in our pivotal phase 3 Elevidys clinical trial, we investigated the efficacy and safety of givinostat in individuals living with Duchenne. So this was an 18-month trial, and it was a randomized, double-blind, placebo-controlled study. So there were 79 individuals who had a confirmed diagnosis of Duchenne, and 66% of those individuals received givinostat, whereas 33% received placebo. Givinostat was administered twice daily as oral liquid suspension. Some important key inclusion criteria for the study is that individuals needed to be at least 6 years of age or older. So what you can see on the top left box here is that the range of individuals that were included in the study were between 6 and 15 years old. The mean age was about 9.8 years. In addition, all patients, they had to be ambulatory, and they needed to be able to get up from the floor within 10 seconds, as well as being able to complete the 2 individual 4-stair climb assessments. They had to do that within at least 3 seconds, but no more than 8 seconds. And finally, all individuals needed to be on a stable course of steroids for at least 6 months prior to starting the study and stay committed to being on that course of steroids throughout the study. So now moving to the clinical trial results. So the primary efficacy endpoint for the Elevidys study was change from the beginning of the study to month 18 on the 4-stair climb. And this was comparing givinostat to placebo. And so what you can see in the table is starting at the beginning of the study, which is entitled mean baseline 4-stair climb here, it's about 3.5 seconds it took for both groups to climb 4 stairs. At the end of the study, or the 18-month point of the study, for individuals who were receiving givinostat, it took about 1.25 seconds longer to climb up the stairs compared to the beginning of the study. However, for placebo, that took longer, 3.03 seconds. And the difference between the two groups was about 1.78 seconds. This was statistically significant, so we met our primary efficacy endpoint. So I also want to point out that in addition to meeting the primary efficacy endpoint, we saw consistent results on secondary endpoints and key secondary endpoints. So what we have highlighted here is that for the North Star Ambulatory Assessment, compared to placebo, there was less worsening in individuals who were receiving givinostat. This was nominally but not statistically significant. And let's talk about the safety of Elevidys. I want to highlight the most commonly reported adverse events for individuals who received givinostat compared to placebo. And so those are diarrhea, abdominal pain, low platelet counts or thrombocytopenia, nausea, vomiting, fat in the blood or hypertriglyceridemia, and fever or pyrexia. So a couple of points here. So first, most of these adverse events, they were mild to moderate in severity. Next, if there was a temporary treatment interruption or a dose reduction, this ultimately proved to be useful in the management of the majority of the adverse events that we saw in Elevidys. And finally, 2% of individuals who discontinued the study due to adverse events. Some important safety information. It's important to note that there are low platelet counts in your blood or thrombocytopenia, increased levels of fat in your blood, or fat or triglycerides. There are frequent or watery stools or diarrhea and vomiting. And before taking Duvyzat, tell your healthcare provider about all of the medical conditions, including if you have any heart problems or if you're taking any medicines that could increase the chance of irregular heart rhythms, or if you have any bleeding problems. Furthermore, tell your healthcare provider about all of the medicines that you take. And we also want to point out that Duvyzat can cause serious side effects, including changes in electrical activity of your heart called QT prolongation. And now I get to introduce to all of you our patient access program, which is entitled ITF-ARC, or Access Resource Care. And similar to other programs that you've seen and presented earlier today, this program really allows you to be able to navigate the insurance landscape, be able to have access solutions, as well as getting education and being able to stay adherent to Duvyzat. We have ITF-ARC, and members at ITF-ARC are there to support you through the prior authorization process. For commercially insured patients, we have the ability to cover Duvyzat, and eligible patients may pay as little as $0. And again, we have the education and adherence resources all through our ITF-ARC, which is now open today. Final slide before getting to the end is that Duvyzat will become available in Q3. We're committed to having that available in Q3 2024. If you have any questions about Duvyzat, please discuss with your child or your your child's healthcare provider. Finally, I want to make sure that we thank all of the participants in the study. Without you, we wouldn't have Duvyzat here in the US, and all of the clinical trial investigators as well. Most importantly, we want to hear from you. We're the new kids on the block as ITF Therapeutics. We want to make sure that we're hearing your feedback. If we don't hear your feedback, we can't change. We want to make sure that we're here with you for the community. So thank you very much.
Awesome. Thank you so much, Scott. Craig, you're going to get your extra 5 minutes anyway, so it worked out. I'm really excited to introduce Dr. Craig McDonald from UC Davis to the microphone. You'll recognize he is not from Sarepta, as our previous two talks were from companies. We recognize that there are a lot of implications with a very, very fresh expanded label. And so we're really grateful to Dr. McDonald because we asked him very last minute to, hey, please come help us understand some really exciting developments that come from this label expansion. So I am really pleased to turn it over to him to share with us some really great updates.
Great. Thank you very much. And I'm really excited about sharing with you this very exciting story about the FDA approval of Elevidys, also referred to as delandistrogene moxeparvovec. These are my disclosures. I've served on advisory boards and done consulting work for Sarepta. So there's incredibly rigorous scientific development and rationale that has gone into the development, really, of all the gene therapy programs. Sarepta's program, Pfizer's program, the REGENXBIO program, Solid Biosciences, and others as well. And any gene therapy using an AAV vector involves a viral vector. This is essentially the bus that carries the replacement gene, a promoter, which really drives the tissue specificity of the gene therapy, so into the muscle, and detargeting other tissues of the body. And then the replacement gene, which is really the important determinant of the functional impact of the gene therapy. So in the case of Elevidys, the viral vector is the AAV RH74 vector. This was derived by a rhesus macaque animal species. It's phylogenetically very similar to AAV8. And there are emerging next generation AAV viral vectors as well that utilize other strains of AAV which detarget some of the tissues such as the liver. But AAV RH74 has an incredibly strong safety profile. And then the MHCK promoter is specifically used, and then the specific replacement transgene. So this is the full-length dystrophin protein seen on the left-hand side, and really this was the microdystrophin construct was really patterned after the small dystrophin protein seen in a patient from the UK. This was a 61-year-old ambulatory patient who was missing nearly half of their gene, but had really the critical components of the gene. And so essentially, the Sarepta gene therapy product and other microdystrophin products are also patterned after this original patient. And you can see the Sarepta microdystrophin construct on the right. And so here we see that, and very similar to other AAV gene therapy products, there are really critical functional elements. There's an actin binding domain. Then there are these hinge regions that also link the, or actually essentially produce a very specific configuration to the microdystrophin protein. So essentially what we're doing is we're replacing a full-length dystrophin, which works as a molecular shock absorber or a spring, so to speak, to protect the sarcolemmal membrane. We're replacing a longer spring with essentially a shorter spring. It has important binding domains onto the sarcolemmal membrane. It has various hinge regions, another region, R24 for microtubule organization, and then a carboxy binding domain as well. And about a year ago, we actually had the FDA Advisory Committee for Elevidys. And I think going into this, there were a lot of people that were skeptical that this would lead to an accelerated approval. But I think Sarepta did a great job really presenting the data, and this resulted in a 8-6 vote actually approving the Elevidys in a 4 to 5 year old, in a Duchenne population. Eventually, this was recommended for accelerated approval by the FDA for specifically 4 to 5 year old patients. And amazingly, the clinicians actually were able to administer the first commercial doses to US patients. Many of these patients were just days before their 6th birthday, and this only took literally about 6 weeks to get this to the clinic and the first patients dosed. And then less than a year later, last Thursday, the FDA actually issued full approval for the Elevidys in ambulatory patients 4 years and older, and actually an accelerated approval for non-ambulatory patients ages 4 years and older under the accelerated approval pathway, which is based on a surrogate biomarker, in this case, microdystrophin expression by muscle biopsy, reasonably likely to predict clinical benefit. So there are a number of clinical endpoints that have been assessed in ambulatory children, including the North Star, time function tests, the 100-meter walk run, and 95 centile stride velocity. And it should be noted that the time function tests are really robust measures which have been used in other regulatory trials. It was used actually in the Agamree trials as well as the Duvyzat trials. And actually, these time function tests are actually a component of the North Star ambulatory assessment. So this is an important concept to keep in mind. If we can treat patients that are actually in the skill gaining phase with a gene therapy product, and hopefully the goal would be to actually get an improvement in function and a higher peak obtained function with subsequent stability. And depending on whether you assess those patients short-term or longer-term, you actually get perhaps a greater divergence from placebo or from the natural history. Or you can, and so you see the placebo patient, you're actually getting a greater improvement in function by treating those patients in the skill gaining phase of the disease. Or you can treat patients who are in the declining phase of the disease, perhaps a bit older, and the goal here with a gene therapy approach would actually be to achieve relative stabilization versus placebo or versus the known natural history. And obviously, as you follow these patients out longer, you get a greater divergence from the known natural history of the disease and a greater treatment effect. So the time function tests are really important clinical endpoints. We've learned much more about these in the last year. They span the entire ambulatory spectrum. They reflect how a patient feels and functions. They're prognostic for overall disease progression. Time to rise from the floor and the four-stair climb have been used in recent registration trials as primary clinical endpoints. So, for instance, the Agamree trial, we had time to rise, and in the Duvyzat trial, the four-stair climb was used as actual primary clinical endpoints. And as it turns out, these time function tests are really more granular and sensitive to change in comparison to the North Star in a young Duchenne population in a short-term trial, a one-year trial. And this is something that has emerged. And fortunately, we're able to actually educate the FDA with regard to the greater sensitivity of the time function test and the greater granularity. So here was the EMBARK clinical trial design. It was a large trial, 125 patients randomized to placebo versus the single IV infusion of the gene therapy product. These patients were all on steroids. They had North Star scores at baseline between 22 that were generally, they were stratified based on their initial North Star score. But they had to have specific North Star scores at baseline. And then after a year's time, the patients who received placebo then subsequently were dosed with the gene therapy product, and the patients that had received the gene therapy product were redosed with a placebo, and these patients were then followed for a second 52-week period of time. And these were the key primary and key secondary endpoints. The North Star was the pre-specified primary endpoint. The trial actually did not show a statistically significant effect on the North Star, but the key secondary endpoints really across all the time function tests and the key secondaries, which were pre-specified to be time to rise and 10-meter walk-run, showed robust treatment effects that were statistically significant in the patients. There was also, this was the first trial to actually demonstrate a significant treatment effect in the 95th centile stride velocity, so a wearable, which I think you'll hear more about that later today in terms of the emergence of wearables as community endpoints that are clinically meaningful. And then in addition, there was trends in the 100-meter walk-run test as well as the four-stair climb test. And what was really quite striking, again, when we actually looked at these time function tests, you can see that really across all the endpoints, to the right of that vertical line is actually the treatment effect would actually favor the gene therapy treated patients versus the placebo. And you can see really with regard to the totality of the data, there's a trend really in significant treatment effects really across most of the endpoints, the key secondary endpoints, as well as the 95th centile stride velocity and the four-stair climb. But this data here I'm showing you actually differentiates the treatment effects in the 4- and 5-year-olds versus the 6- and 7-year-olds. There was a lot of discussion that perhaps this therapy only works in 4- and 5-year-olds. But this EMBARK trial actually demonstrated that there were not only statistically significant results on the key time function tests in the 4- and 5-year-olds, but there was also significant treatment effects seen in the 6- and 7-year-old patients as well. So even the patients that were more severely affected and even in the decline phase of the disease were showing a treatment effect on the time function tests. And this, in terms of really making this point with the FDA and doing some education here, it was really, I think, became evident to the FDA that the time function tests were more granular and more sensitive to change in comparison to the North Star. So this, for example, is looking at the North Star item, the rise from floor item on the North Star, and that can be scored 0, unable to perform the item, 1, perform with compensation, or a 2, normal function. And it turned out that in this particular trial, because of the inclusion criteria, 90% of the placebo patients actually had scores essentially, virtually all patients had scores of 1, and 90% of the patients really showed no change over 48 weeks. And you wouldn't expect patients in this age range and this level of function to actually completely lose the ability to rise from the floor and transition to a 0 score. So really the only way you could possibly demonstrate a treatment effect on this North Star assessment would be if the gene therapy treated patients transitioned from performing the task with compensation to a score of 2 or performing it normally. And here, actually, when we look at the EMBARK results, looking at time function tests, the red are the placebo patients, the blue patients are the gene therapy treated patients. You can see deterioration on the time function test, rise from floor in the placebo patients, and actual improvement in the gene therapy treated patients. So just to point this out, here's a patient who's 2 years post gene therapy, gets up from the floor, but just that little push off that left knee gets him a score of 1, and so essentially on the North Star he would be unchanged, but obviously with his time function test he has very robust treatment effect. And in fact, on the time function test, we see, looking at both the 4 and 5-year-olds and the 6 and 7-year-olds, this is the time to rise. So the yellow patients are the placebo patients, and again, in the middle panel there, the placebo patients are showing relative stability, but the gene therapy treated patients are actually showing improvement in that time function value. And then if you go over to the right panel, the 6 and 7-year-olds, the gene therapy treated patients are actually showing stability or a little bit of improvement, whereas the placebo patients are actually showing quite a bit of deterioration functionally on that endpoint. So you can see really the power of the time function test. And similarly, with the 10-meter walk-run tests, again, the 4 and 5-year-olds, we see greater relative improvement in the middle panel, statistically significant with the gene therapy treated patients versus the placebo patients who showed relative stability. And in the 6 and 7-year-olds, the gene therapy treated patients are remaining stable, whereas the placebo 6 and 7-year-olds are actually showing deterioration or decline. In addition, we know from natural history studies conducted by the Synergy Group and the CTAP group that the time to rise is actually a predictor for either functional stability or functional deterioration. And when you transition to a time to rise value of greater than 5 seconds, that's really a predictor for the onset of functional decline or functional deterioration. And so if you look at the natural history data, the patients with peak rise times greater than 5 seconds, that's the blue, they have a much earlier time to loss of ambulation, whereas the patients who are peaking later at 3.5 seconds to 5 seconds, or even less than 3.5 seconds, are actually continuing ambulation much later. And in fact, when we look at the EMBARK data, if you look at the gene therapy treated patients, this just shows the hazard ratio, looking at the hazard or risk of actually progressing past that 5-second rise time. And there's actually a 91% reduction in odds across all of the patients in the trial for risk of transitioning to that functional deterioration threshold. And in the 6 to 7-year-olds, the risk reduction was about an 89% risk reduction. So again, I think showing the clinical meaningfulness of this change in the time function tests. And then we know that from Dr. Mendel's work in the 101 study, these patients are actually maintaining stability for really quite some time after an initial improvement. This is North Star data. And the blue is the gene therapy treated patients. They show a higher peak obtained value and then a long-term stability out to year 4, whereas the external control patients were beginning to show functional deterioration by the time they get out to 2 to 4 years. And in fact, if we look at each individual patient and their predicted trajectory, This is based on some modeling that has been validated by the CTAP group. Each patient actually has a more favorable trajectory than their predicted trajectory based on their initial function. And this is actually videos we had teed up at the AdCom. We actually didn't have time to show them, but these are actually not cherry-picked videos, but these are 5 patients I've treated, and this is these 5 patients 2 years out after treatment with gene therapy. This is the patient on the left is a 7-year, 4-month-old, 25 months post. The next patient is 7-year, 11-month-old who's 2 years out from gene therapy. And you can see these patients just do not look like Duchenne patients. Here's an 8.5-year-old who's 28 months post gene therapy, and then a 9.5-year-old patient who is 2 years post gene therapy, still running. And then on the far right, actually, a nearly 13-year-old who's not running normally, but still is running nonetheless, who's about 2 years post gene therapy treatment and still running nonetheless. Now, I saw these same 5 patients a year later, so this is now 3 years out after treatment with gene therapy. Here's the same patient on the right, continuing to run. The next patient, 8 years, 11 months of age, maintaining the ability to run. Here's a patient who's over the age of 9, who's 36 months out, again, continuing to run. Here's a 10.5-year-old who's now 3 years out from gene therapy, maintaining running ability. And then finally, the patient on the far right, who's actually now 14 years of age, who's 3 years out from gene therapy, and is still able to run. Not normally, but still running nonetheless. So let's get into the new expanded label. This is really exciting. The gene therapy is a adeno-associated viral vector-based gene therapy indicated for the treatment of Duchenne dystrophy patients at least 4 years of age, and for patients who are ambulatory, again, a confirmed mutation in the Duchenne gene, same with the non-ambulatory patients. But the indication in the non-ambulatory patient is approved under the accelerated approval pathway based on expression of the microdystrophin gene therapy product in skeletal muscle on muscle biopsy, and continued approval would be contingent upon verification of clinical benefit in future confirmatory trials. The contraindication remains, again, any patient with a deletion in exon 8 and or exon 9 in the Duchenne gene, so patients with deletions involving exons 8 or 9. And this is a new actual warning and precaution. Infusion-related reactions with the commercial experience. There were some emergence of some infusion-related reactions of about 1 to 2%. And so we have to be aware that this is a possibility and be prepared for treatment. And I think this really highlights the importance of patients being treated at centers that are quite experienced in the use of gene therapy in Duchenne patients. There was a patient who was actually had an infusion-related reaction, which actually the dose was actually unfortunately had to be suspended or discontinued. And I think these can be prevented if patients are treated at centers that are experienced and prepared to deal with infusion-related reactions. There continues to be a warning with regard to the onset of acute liver injury. There continues to be a precaution with regard to the rare possibility of immune-mediated myositis, and then also myocarditis, which really requires patients to be monitored closely with troponin I values. And the pre-existing antibody testing is also a requirement. The most common adverse events seem to be vomiting, nausea, liver injury, pyrexia, and thrombocytopenia. And again, this is the data that led to the accelerated approval in the non-ambulatory patients. You can see 40% expression of the microdystrophin protein using specific biopsy techniques. But that data was again based on 8 patients. All of the patients that have been dosed to date have had left ventricular ejection fractions greater than 40%. In the label, there's actually some efficacy data. The time function test data is actually included in the packet insert. And this, again, is the clinical trial experience in terms of the proportion of patients that experience vomiting, nausea, liver injury, and thrombocytopenia in the packet insert. Again, this is the data of the adverse reactions, at least occurring twice or more frequently than the placebo. So again, vomiting, nausea, liver injury, thrombocytopenia. So I think just to close, I think, in terms of definition of ambulatory, this is going to need to be documented carefully by the prescribing physician. What about prioritization? It'll be an interesting discussion here as we move to the next panel. At least my approach might be to at least consider initially the late ambulant patients who are on the verge of losing ambulation so that it could be prescribed within the full approval label as opposed to the accelerated approval label, which might make it easier in terms of third-party reimbursement. I think we have to be prepared. You have to be treated at centers that have experience and be prepared to deal with infusion-related reactions. There's also different approaches in terms of exercise protocols during the infusion, feeding protocols in terms of having patients NPO and so forth. Manifesting carriers, that question came up. That would be considered off-label treatment. But I think this safety issue is really quite important to consider. All patients to date that have been treated have had left ventricular ejection fractions greater than 40%. And most patients have had percent predicted forced vital capacity greater than or equal to 40%. So it's not an absolute contraindication, but I think the treatment centers are going to have to really approach this with significant caution. So I think for the future, we have next generation gene therapies. We have a very exciting approval for Elevidys. There's next generation exon skipping drugs. We have combination therapies. There's new transmission vectors, new promoters, different manufacturing approaches, and replacement genes that have really strong scientific rationale, cell therapy that's being studied, and I think it's a really exciting time for combination therapy. So with that, I will conclude, and thank you very much.
Thank you so much, Dr. McDonald. That was fantastic. At this time, I'm going to go ahead and invite my panelists for this next session to join me on stage. And we're just going to talk about these approved therapies and how to kind of approach these conversations with your doctor. As I wait for them to join me on stage, I do want to flag a couple of things for you. One is, in this landscape with new approved therapies, access is really, really important to think about. We have our FDA label, but then we have insurance, we have payer policies, we have Medicaid, we have all of these different things to consider in terms of how we actually gain access to these drugs. So one resource is Little Hercules Foundation, with whom we're really pleased to be able to partner. They offer fantastic case management and are able to walk with you every step of the way through that prior authorization and appeals process. They and several other folks are available for one-on-one appointments with those in-person PPMD for you slots while you're here at conference. You can go into your CVent app, you can schedule time with ARC, and you can schedule time with Little Hercules or the PPMD genetic counselors, whomever. So go check that out. And then that resource is available after conference too, virtually. So let us connect with you, let us provide that insight. The other thing that I'm going to flag is that I recognize that we've got 8 approved therapies, and I've got about 40 or 50 minutes for us to try and talk through that, and that's pretty much impossible. So what I'm happy to share is that you will probably see in your app, if not now, within the next few minutes, we've actually added an additional session tomorrow evening at 6 p.m. to close out the day, and we're going to talk specifically about the expanded label for Elevidys. I am sure that you all have questions, as I do too, and so we're going to bring some experts up, and we're going to talk through it. How to approach that expanded label. What questions do we have? How do we talk to our doctors about decision-making and understanding of some of that nuance and implication? So as we work through this session, we will absolutely welcome your questions. But of course, I just want to remind us all that the intended purpose of this specific session is the entire approved therapy landscape with dedicated time tomorrow to really, really think more closely and specifically about Elevidys. So with that, if we could go ahead and pop up my first slide. I think you already know me. I've been talking for a while now, but my name is Rachel. I'm part of the care team at PPMD. I came from the clinic, and I'm just really happy to be on an amazing team that gets to forge relationships with folks like you all to, partner together and think about all of the things that relate back to clinical care. I think what we can do, I have a slide with all of your names on it, but I would like to hear from you all instead. So if you could each just go down the line and take a moment and introduce yourself, your name, your subspecialty, where you're from, and if you have a fun fact. But you don't have to have a fun fact, it's fine. We'll go ahead and start with you.
Hello, everybody. Can you hear me okay?
Yep.
Yes, all right. My name is Omer Abdul Hamid, and I'm a neuromuscular neurologist here locally in Orlando, Florida. And an interesting fact about me, this is one I usually tell, is that I'm a second-degree black belt in Taekwondo.
Oh, we're actually going to get the fun facts. This is great. Okay. Dr. Proud.
I'm Crystal Proud. I'm a neuromuscular neurologist at the Children's Hospital of the King's Daughters in Norfolk, Virginia. I see both pediatric and adult patients with muscular dystrophy. And a fun fact about me, I live at the beach and I have my boater's license.
Hey guys, I am Veerapandiayn. I also go by Panda. I'm a neurologist also from Arkansas Children's Hospital, and it's really great to be here. And we'll get all of your questions answered by end of the session, everything.
Yep, you're good.
I'm going to skip that.
Hi, I'm Diana Bharucha-Goebel. I'm a physician and pediatric neuromuscular neurologist at Children's National in Washington, D.C. And I think the other one was fun fact. Let's see. Interestingly, through marriage in our family, we're distantly related, actually, to Freddie Mercury.
Hi, I'm Paula Clemens. I'm a neuromuscular neurologist, actually an adult neuromuscular neurologist at the University of Pittsburgh. So I take care of patients who are adults with Duchenne and Becker, also a researcher. And it's a fun fact, it's really hard to hear actually ourselves up here. So I guess my fun fact would be that I was at the second PPMD conference in Pittsburgh back in 1996, I think it was.
So you're an OG, I think is what the kids say, an OG, yeah.
What did you say?
You're one of the originals, so we're really glad that you're all here. And then again, I already introduced myself. My name's Rachel. So I am super looking forward to digging into this conversation. Just as like a heads up to you all, I'm having a hard time hearing you. So with the feedback, if I'm like, just be a little bit patient with me. So we're thinking about all of these different drugs. There are 8 of them. Some of them are broadly applicable. Some of them are not broadly applicable. And that's something that we really need to think about in terms of what to start and when. What's the right time? What's the right combination of drugs? And we also recognize, too, that there aren't really any studies that are taking these drugs and comparing them head to head. That's just not really what we see in a lot of drug development. We don't get these studies that are going to take drugs and say, drug A, drug B, which one is better? It's just not where we are in this moment in the Duchenne landscape, and that's okay. So as you'll see up on your screen, it's a quick overview of all of our currently approved therapies. So we have Emflaza, which is also known as deflazacort. It is a corticosteroid, and it's currently through the FDA label available for individuals ages 2 and up. No genetic requirement, no ambulatory requirement. We're pretty familiar with this one. It recently went off patent, so you might be going through the process of transitioning from brand to generic. We also just heard from Catalyst about vamorolone, brand name is Agamree, which is talked about as a steroid in a couple of different ways. You might have heard it called a dissociative steroid or a non-classical steroid, but we're going to think about it in this same bucket of steroids. And again, we see a label for ages 2 and up, as it's a steroid, no requirement for ambulation or genetics. Then we move into our exon skipping drugs. So we have, a few different that are going to be applicable to only a certain set of individuals based on that targeted variant-specific therapy. So Exondys 51 is an exon skipping drug for those who are amenable to exon 51 skipping. Same with Vyondys 53 for those who are amenable to 53 skipping, similarly to Viltepso. And then Amondys 45 is going to be an option for those who have a variant that is amenable to exon 45 skipping. We also just heard from Dr. McDonald about Elevidys, which is a gene therapy, a microdystrophin gene therapy, and we just recently saw this expanded label. So we previously were thinking about it in confines of those who are 4 and 5, but now 4 and up is what we're looking at. And that only real genetic requirement is just no deletion of exons 8 or 9. And then lastly, Duvyzat, which is going to be that small molecule HDAC inhibitor for those who are 6 and up. So I think, oh my goodness, that's a really long list, which is great. But that's a lot to think about, especially if you're a family of somebody who is newly diagnosed and you're learning the language of Duchenne, or perhaps you are an adult with Duchenne and maybe you just haven't really been thinking about these things as much because you felt like there wasn't anything available for you. I think that no matter where you are on the spectrum, you bring a unique perspective to decision making and how you engage with your physician, and that's really complex. And so I think where I might start is with you, Dr. Panda. If you could just kick us off, I love that face, oh my goodness, don't call on me, with just a very brief introduction into how you start to think about decision making with a family when they meet you in clinic and say, hey, what do you think? Where do we start? How do we go about this?
So why would you pick me? I don't know, for first.
Because you're in the middle.
So I think it's fun time to be in the clinic. It's a good problem to have. Like I hear from my mentor always, it's a good problems to have now. When you think about how to approach, depending on who you are talking to, if I'm talking to a newly diagnosed family, I think even just to talk about the diagnosis and explaining that in terms of what it is and what's the prognosis, what are we going to be working with the rest of the life, I think that in itself takes a lot of time. And what you discuss during that first visit, not all of them actually register in them. So I think you may have to consider bringing them back a couple of times to discuss more. If you look at the therapeutic options, I think I categorize them as steroids are not going to go away. So I think that's the first thing I talk about, obviously. Then you talk about the different types of steroids that we have, all three of them, prednisone, deflazacort, Emflaza, and vamorolone, and kind of talk about the pros and cons and decide which one you want to choose. If you think about the, if someone that's actually, it's a kid who would be eligible for Elevidys or gene transfer therapy, right, then you may want to include that in your discussion first from a steroid perspective. You may want them to be on prednisone anyway because they have to be on prednisone as a peri-infusion for Elevidys. I think that may influence the decision. Then after the steroid discussion, of course, you get into the genetic targeted therapies to discuss that and see if they would be eligible for an exon skipping versus, again, the gene transfer therapy, and pick, again, same thing, pros and cons, and see which one would be an appropriate one for that specific kid. I think there's a lot of options we can discuss about. It's going to be in the individual boy. I think it's that family itself, because you're setting expectations, the goals for the treatment, and that's going to vary from one family to the other family, from one boy to the other boy. So I think getting that information and finding a treatment regimen that's going to work for that individual boy in front of you is going to be the key. I can keep going on, but keep on going. But
So, Dr. Proud, with this expanded label, and as I shared, this isn't necessarily the singular focus of this conversation, but it goes without saying, like, we have a broad label for Elevidys now, but all of these other therapies. So talk to me about how you might order these therapies. So as Dr. Panda mentioned, we're thinking that we need to have a steroid on board anyway because of safety reasons too. So we're probably going to start with that before we would consider something like an Elevidys. But talk to me about, a child who is 2 or 3, so maybe they don't have eligibility for some of these drugs versus somebody who's a little bit older. How would you think about this sort of sequential addition of therapies?
I think it's a really important question to think about the ordering and the most appropriate way to order the treatments that we would consider for our boys with Duchenne. So one of the ways to organize these therapies is just what Dr. Veerapandiayn just mentioned, which is looking at their mechanisms and their goals. So are they attempting to restore some form of dystrophin? Are they trying to stabilize the muscle structure? Are they trying to prevent fibrotic change? And in what order do we think it might be the best if we could choose, if we could start at the very beginning? In addition to talking about the currently available therapies, I also think about what might be coming down the therapeutic pipeline. Is what I'm going to do now going to potentially exclude your child from participation in another great opportunity that may avail itself to you? And in what time period do I think that that might be most appropriate? So for many of my patients, as we're navigating these discussions, I'm really trying to think in terms of the next 6 months, for example. Can we make a decision in the next 6 months regarding what might be the best for your child? And if I don't see that there might be a potential for participation in clinical research that may be potentially life-changing or life-saving, that would be distinct from what I have available commercially, then we should stick to just looking at the currently commercially available therapies that were listed here. And then likewise, if I choose a commercial therapy, could I potentially enroll you in a clinical trial subsequently? So these are all things that we should be thinking about as we're navigating these choices. If I have a brand new young patient who perhaps doesn't have the eligibility yet for, say, Elevidys, then is there the potential to enroll them in a clinical trial where they would be able to receive that gene transfer therapy early or another gene transfer therapy early? So I would discuss that with them. Or provide a baseline foundation with corticosteroids to stabilize the muscle structure. Can I get some exon skipping amenability from the patient, and once again lay a foundation that then I could pursue eventual gene transfer for? But I do think that probably especially for those initial diagnoses, I would be looking at initial gene transfer and then the potential to pursue some of those other therapies additionally. You mentioned some of our older folks as well, and I have the great privilege of having treated some of the older patient population. I've treated the oldest boy with SRP 9001, or a gentleman, shall I say? And so I do think that discussing eligibility and safety and considerations for potential benefit in those older guys is also incredibly important.
I think that's really helpful. Go ahead, Dr. Panda.
Adding that clinical trial discussion, it adds another layer of challenge. We have available therapies and we have these potential trials, and it's always hard when families ask us, right, hey, should we go now or should we wait for the best in the future? I think there's a lot of uncertainties there, and we have to have the discussion very balanced, very carefully, because the company may say 6 months, but they may have other plans. 6 months later, hey, no, it's going to be another 6 months. So I think we may have to keep that in mind when we have the discussions. So whatever we have in hand, just go with the best approach what we have.
I think you both highlighted the really great point that it's not just approved therapies, it's approved therapies in the same conversation as clinical trials and how these two things interact or don't. So thank you for that really helpful and thoughtful feedback, Dr. Proud and Dr. Panda. Dr. Clemens, you're the lone adult provider up on this stage. And so these conversations are probably a little bit different from your lens. So enlighten us. How do you think about these conversations? I know one of the questions that I get very, very frequently is, hey, we just haven't really been paying attention to the clinical trial landscape because we don't think that there's anything there for us. And so now we see these new approved therapies and we don't know what they are, we don't know what they mean. Enlighten us. How do those conversations look for you, and how do you approach this concept?
So yeah, it is a pretty different conversation, I think, when in the adult phase. For one, by the time the patients are adults, they're participating in the conversation. And they've had their own lifetime to experience what it's like to live with this disease. Generally, adult patients, still their parents are very much involved, so it's very much of a family, kind of a family decision about different treatments. At this time, most patients in the adult phase are on steroids, although some go off of steroids because of a lot of the complications that happen, particularly if they start having infections and that kind of thing. So I think, like any medical decision, is very much a risk-benefit decision. And when patients are older, they're more medically fragile, and they need to sort of think about these things in perhaps a little bit of a different way. So I haven't actually had a lot of conversations yet. I think the other thing to remember is that a lot of the therapies, exon skipping, gene therapy, really depend on being able to treat muscle tissue. And as one gets older, one has less and less muscle tissue with this disease. So there's sort of less of a target. So these are all things that have to be weighed in terms of the risks and benefits, and clearly it's a conversation with a medical provider.
I think that's great. Dr. Bharucha-Goebel, what would you add to that?
Yeah, so we gave some examples of like a younger child in clinic, so maybe, and then adult. So maybe if we're thinking perhaps about an adolescent, thinking about with the expanded approval, maybe exon skipping. If you have, let's say, an adolescent who's in a exon 51 amenable, skipping amenable mutation. On therapy, how do we think about that? And so again, I think it does. When thinking about these treatments, even if you're thinking about the genetically targeted therapies compared to the steroid or muscle targeting or supportive therapies to the muscle, one thought is, the risk-benefit for any given patient based on their function, again, the extent of muscle involvement, and the risks of that therapy at that time. So, I also think about, for example, with exon skipping, if it was not tolerated, you can stop it. With gene transfer, you cannot withdraw that. You cannot take it back. So what does the safety profile look like for the individual that I may be considering a treatment for? Are they stable on a therapy, and how do we make that decision for potential switch? So these are, I think, new thought processes we're going to shift and pivot towards as we're thinking about this, especially also in the older individuals, which has been a little bit different clinically than the conversations we've been having over the past year, with some of our younger families and patients. So just when we're thinking about that, the exon and genetic targeted therapies.
Excellent. So lots of really helpful perspective on some of these genetic-specific targeted therapies. But we've got 2 approved therapies that are brand new and broadly applicable. So Dr. Abdul Hamid, talk to me about how you think about potentially switching a patient from one drug to another drug in the corticosteroid landscape. Maybe we're switching from, deflazacort to Agamree or prednisone to deflazacort. How do you approach that decision? And then talk to me also a little bit about consideration for things like Duvyzat that are going to be broadly applicable, seem to have a pretty good safety profile. Just kind of talk me through your thought process.
Yeah, so in general, as a community, we really support therapies that are what we call applicable to everybody, meaning that it doesn't matter what your genetics shows, it doesn't matter what other antibodies you may have. This is really applicable across a broad range of patients with Duchenne so that people aren't left behind, which is amazing. We love to see that. When talking to patients about switching, it's not as complicated as you might think to actually switch. It does take a lot of work on our part, on the back end, to try to get the insurance approval, but that's our job. That's what we want to do. So please don't shy away from asking your providers about switching if you really are interested in learning more about newer agents. They might not be right for everybody, right? So there are side effects that we need to discuss, and they're just different than prednisone, right? So really, it's having a conversation, really making sure that the patient's family and the patient have all the information that they need to make an informed decision about switching, and if it's right time for them and their family to do so, and then let us do the hard part.
I love that. Let your medical team do the hard part. They are there to support you. They are there to help you navigate this. You're not in it alone. Shameless plug, PPMD is here to support you through that too. I am absolutely delighted to have the teammates that I do in Brian and Alexis and Amanda, in our partnership with people like Kelly and her team at Little Hercules to really come alongside you and help you figure out how to access these drugs. So once you make a decision with your medical team, let us help you come alongside you and get you that access, because we don't want there to be barriers that are difficult to overcome when there's a therapy that you and your team have decided is the most appropriate plan.
And then, once we actually get approval, the actual switching isn't very hard either. We actually, doesn't matter what kind of steroid regimen you were on before, we switch everybody over to the 6 per kilo dose, daily dose. Because Agamree can have some effects on the potassium level, we really don't recommend doing the weekend only. We don't think that's going to really be beneficial because of that risk. So it really is limited to just a daily dose. Now there are different doses that you can use: 6 per kilo, 2 per kilo, even in the trials 4 per kilo were allowed. So we can play with the dose that way, but it really doesn't truly matter what you were on before. It's easy to switch everybody.
Go ahead, Dr. Bharucha-Goebel.
No, I was just gonna. Go ahead.
Just on the topic of the steroids, so I think another interesting thought I have in my head is really the need for that ongoing long-term data, which will help us as well. So it's a dynamic situation. What we know today and what we'll even know a year from now is going to be different. And so as was spoken about earlier today, with efforts in looking at cardiac outcomes, bone and endocrine outcomes, registries, these are so important to feed back to the clinical information that we can use as those added data points in guiding our families and the kids and young adults who we're caring for. So, for example, with vamorolone, we have learned about from the data, some of the favorable impacts related to the bone health and the bone markers, height velocity and whatnot. But there are maybe ongoing questions about what will its impact be on cardiovascular health, on the progression of fibrosis and or respiratory health or scoliosis. So these, with these exciting new therapies come also exciting questions that we need to answer together. So again, the ongoing need to keep looking into this across our clinics, and to really, as a network, is so important.
Go ahead.
I was going to add, I think, we're talking about steroid discussions, right? It's exciting to have multiple options, but I usually tell my families that just because you have a new drug and market doesn't mean that you have to switch or start already. I think having the conversation, again, going back to what is your goal? Why are we thinking about switching that? What is that whatever medicine you're going to switch is going to address that goal. I think that having the conversation is extremely important. And of course, with Duvyzat, again, is look at the risk and say, is it going to be good for my kid? I think, again, having that discussion with the provider. Another thing I want to point out is it's not solely decided by just by a neurologist and the family, right? So with the newer therapies, there's complications that you have to have cardiologists and endocrine and some of the other specialists, your care team at your center to be involved when we make these decisions. I think it's critical to have that in mind. You can even ask your neurologist, hey, or a cardiologist, what do you think about if you want to switch? And make sure the team decide. It's a team decision along with the families.
Go ahead.
Yeah, and just maybe just expanding a little bit on something that Diana said. I think it's important to remember that clinical trials are really just the beginning, and there is such an importance to then contributing to the natural history, because we now know that the natural history is changing, and so we need to continue to collect that. So just really wanted to emphasize the importance of observational trials as well as treatment trials as we collect all this information going forward. Really, there were randomized clinical controlled trials for prednisone, in like 1990. And all of what we learned in those was then further confirmed by the natural history studies that were done in the subsequent period of time. And that's so valuable because then you have a real knowledge that something has a really long-lasting, and you can start to expand on what you learn in a 6-month or 12-month trial.
Absolutely.
To add to that just a little bit, we also know that some of our clinical trials are not complete yet. And so if we look at some of the Elevidys clinical trials in our older and non-ambulatory patients, it's incredibly important that we continue to collect this data, that we see these clinical trials through to fruition, both in the US and outside of the US, because this data is going to be incredibly important for receiving insurance authorization for patients that desire treatment, for hopefully helping agencies outside of the United States that need this data in order to achieve approval, so that hopefully there is global applicability and access as much as we possibly can see. And so it's really important also to continue to highlight the efforts that go into these continued clinical trials in our patients now, and then where we see those expand. Can we look at combinations and add-on therapies? Is that going to be in a separate clinical trial program or in some more of these observational gatherings that we get from registries and other data collecting capacities? So thinking about where we go from here is really exciting, and like Diana said, it's great to see such wonderful opportunity, but it comes with still a lot of question.
We're kind of entering a wild, wild west area. We have all these different medicines, which are great. We love to have options. And, we're trying to talk now about what the optimal cocktail solution might be. And we may find that answer, but we also have to think that we may not find that answer. And that, like Dr. Veerapandiayn mentioned, everybody is different. So one combination might work for somebody, while another combination might work for another person.
That's such a good point. That is such a good point. And I think a couple of the things that I heard you all say, and I think you really highlighted it, Dr. Abdul Hamid, is that, one, you don't have to switch if there are 2 drugs available to you that have somewhat similar mechanisms of action. You don't have to, but you can, and you should do that under the guidance of your doctor as you're talking through pros and cons and weighing benefit and risk. But something that Alexis and I actually will say quite often as we think about this decision making is that it is okay to change your mind. You can make a decision today and you can see how it goes, and maybe it's in 3 or 6 months, or maybe it's next year, but it's okay to change your mind. You're not locked in. Now, if you are on daily steroids, you can't change your mind without talking to your doctor first, but you can change your mind, and you can work with your medical team to pivot and to adjust and to come up with a new plan each 6 or 12 months or whenever the timing is right. And I think that it really highlights to me the importance of having that neuromuscular team that you can really trust, that you can ask these questions, that you can talk to about these things. The other piece that I was hearing from a few of you was the importance of data. And I just have to again highlight the importance of the Duchenne registry, which is a patient-reported outcomes registry that we maintain at PPMD, but then that other side of it being the interchange, which is a really important way that we can get data from your medical record, with your consent, of course, to look at the long-term effects of some of these approved therapies, both in isolation and in combination with some of these other drugs, because there's not a really great model right now to look at these different therapies being used alongside one another within an individual over time. So that's something that we would be happy to dig into more. I'm looking at time. We could do this all day. I want to open up the microphones. So if you look, we've got a couple of stand mics here. I would love to hear your questions. So there's nothing really off limits. So bring your questions to the front. And as you make your way to the front, I am going to pose one more question of my own to the group. Newborn screening is here. It is happening. We are actively screening babies in Ohio, where I am from. We've got 2 other states that are coming online and have passed legislation. We're looking at a RUSP vote in the very near future. How do we think about this entire conversation as it relates to these babies, toddlers? I know we have several families in the room with itty bitties. How does that flavor this conversation?
It's going to be challenging. It's going to be tough. There's a lot of, to even figure out, we talk about a lot about genotype, phenotype, and what mutations that they have. It can even predict. Some of them we know this is going to be a Duchenne phenotype. Some of them we know it's going to be a Milder-Becker phenotype. But there's still uncertainties there. Right? So can we figure? So what are we going to even diagnose them or label them as? There was a lot of discussions about should the term be changed to dystrophinopathy and kind of treat everyone. So even that in itself is a challenge. And then if you introduce the therapeutic landscape, but discuss that. Definitely steroids, we have used in younger ages. If it is a typical Duchenne genotype that we know, then, we're gonna steroids we can use as 1 year old, 2 years. There's Duvyzat and Vamolor approved for 2 years. And exon skipping agents we have used, in younger kids 6 months if they are amenable to exon skipping. So those are good options. And I'm sure we're gonna learn more from. I know that recently we had a meeting in New York on the newborn screen and the project. I think we're gonna learn more from that, the data collection from those newborn screen efforts.
Dr. Abdul Hamid, do you have anything to add to that?
Yeah, I think I agree exactly with what you said, and I don't know that any of us really truly know what we're going to do with our newborn screens, which is great. We're excited to figure that out, and I agree with everything you said so far.
I would add that I think the great thing about that conversation is that we can be incredibly honest with our families of the youngest boys with Duchenne in saying that we don't know what the future holds, and that's a really exciting conversation to have because our previous conversations have been a very clearly laid out natural history, and to be able to say to all families in the room, including those families of our older guys, that we don't know what the future holds, but we're full of optimism for what that future holds is an incredible gift, and we are all very thankful to be a part of that conversation.
Absolutely. All right, Diana.
I know, just to echo the sentiments, I think my biggest concern would be around the genetic characterization and how precise we can or cannot be with a family, and the angst that might create if it is unclear, and how do we navigate that. from newborn screening. On the positive side, of course, the earlier access to therapies and treatments, we can hopefully avoid some of the late diagnoses. And sometimes families have been going from seeing physical therapy, seeing orthopedics, seeing different specialists, and then maybe a delay to diagnosis as well. And so hopefully this streamlines that access to care, gets them plugged into care earlier, which would be a huge benefit for therapies, for services, for shortening really that diagnostic odyssey and avoiding those delays. So that has me very excited, that part of it.
Awesome. All right, let's take a question. I think I see Deb Jensen at the microphone. I'm glad to see you. What is your question?
I'm glad to see you too. Put this down a little bit. I have a question that's specifically about Agamree. There was the presentation today, and I've looked online at all the data, and there's nothing out there that's comparing its effectivity with deflazacort or with prednisone. And so, I don't know how you can make a decision when you can't even see that data. And then secondly, when they looked at side effects compared to prednisone, they didn't look at weight gain, or maybe they did and there was no difference. But either way, it would be really nice to see some of that data, because to me as a parent, the effectivity is more important than anything really, especially if the side effects aren't that much different. But so I'm just curious if that data is out there, and if not, have you guys seen differences depending on the different types of steroids and effectivity? Thanks.
Yep, go ahead.
Yes, I'm happy to answer that. So you're right that there are no direct comparisons between vamorolone and deflazacort. There are indirect comparisons which are a bit problematic. So it is a challenge, but the thing that I like to counsel patients on is that at least now we have another option. We can try something, and like you said, you're not locked in. So if you're having some of the side effects that are intolerable to you and your family, then you have another option. We can switch. Now, in terms of the weight gain, the boys in the study did have an initial weight gain as compared to prednisone, which was higher. Now, they also had they were taller, they grew taller, so it eventually actually evened out, and their weight was of a normal BMI. So there is an initial weight gain, but as they get taller, it should even out.
Awesome, thanks. All right, let's go over here.
Hi there. I have more of a statement than a question. When you're in clinic and you're talking to the boys about therapies and stuff, you need to include mom, especially if she's a carrier, so that she's aware that these things, once they're open label approved, she may qualify because she needs to be there for her son. And with our boys living 30s, 40s, 50s, mom needs to be there also. She needs to be included in all of this. Thank you.
This is so important. This is a conversation that we've actually been having internally at PPMD about advocacy with payers and understanding how these policies are created, because we might see a label that is broad or nonspecific and doesn't say boys or men, but it just says Duchenne or it says dystrophinopathy. And how does that translate from a label to actual implementation and access? I don't know if anybody on the panel has had any, luck getting symptomatic women or girls access to some of these approved therapies, if you could speak to that.
Yeah, so there are, manifesting female carriers that we take care of, and, we talk to them about steroids, and that's kind of where we kind of treat them like a Becker patient almost, when some of them can be even closer to a Duchenne patient, right?
Mm-hmm.
So it's just finding where that patient is and meeting them halfway and talking to them about their options. Usually it's steroids, some regimen of steroids.
So we have a lot of work to do in this area. All right, Kelly.
Hi, Kelly from Little Hercules. Thank you, Rachel, for acknowledging the work that we've been doing together to remove access barriers for Duchenne patients. I just want to say a lot of the families that have been coming to us lately since the Elevidys label expansion, they're very worried about asking for a new treatment or a different treatment, especially if they've been on an exon skipper for a number of years or Emflaza or something like that. And I just want to mention that it is your right to find the best treatment plan with your provider. That's a decision that you have every right to make with your Duchenne doctors, regardless of cost. Nobody comes to us patients and asks us how much they should charge for these treatments, and it has nothing to do with us in this country. So I just want to remind you of that. And then to the clinicians that refer patients to us when they get that first denial, please continue to do that. That is so critically important. We've been very successful in getting the regulators involved in these decisions. These regulators have stepped in and overturned many of these denials for our Duchenne patients. And then we also, can get their elected representatives involved. So I just want to thank the clinics for sending patients to us and working with us, in collaboration for each and every family and patient.
Thank you so much, Kelly. We're all better when we work together. All right, over here.
I have a question about older Duchenne patients. Your studies seem to concentrate on people around 10, where of course effects are more easily measured. My son is 32. Are you planning anything for that age group where effects of, say, gene therapy may not prolong ambulation but actually save life?
Who wants to take that one?
I can speak to the clinical trial work being done with the Elevidys program in those older and non-ambulatory patients. So there is work being done to expand the applicability for treatment to that age group and to those older age groups. When we think about utilizing a gene transfer in those age groups, in particular, we have to think about safety as priority, right? However, just because we see that the disease is further progressed, this does not necessarily mean that those guys are going to be precluded from therapy. We need to think about the potential adverse effects of these treatments and how we might mitigate or manage those adverse effects. We've examined, at least in the boys that have been treated that were older and non-ambulatory with Elevidys, we've seen that there's not necessarily been a correlation between age and an adverse effect. But we know that even if those older guys are going to have the same adverse effects, sometimes their ability to manage those adverse effects are going to be a little bit different. So if, for example, they have nausea and vomiting, what is their pulmonary status, and can they manage to maneuver their secretions adequately while they're having nausea and vomiting? Can they protect their airway? If they have dehydration, is their cardiac status able to be supported sufficiently so that they don't have a cardiac adverse effect? And we've been able to successfully do this in some of our older and non-ambulatory guys with Duchenne, but it bears conversation, it bears a discussion about pros and cons with your medical team, and setting up a plan to optimize that safety. And that's going to be an individual discussion.
Dr. Clemens, would you add anything to that as our adult provider?
So unfortunately, it's very difficult to hear what we're all saying. So I can hear what you say from me. So was the question, though, was about a 32-year-old, correct?
Yes.
Yeah. I mean, I think one needs to be very careful with patients that are in that age group. And I think most of the treatments that are addressing, dystrophin restoration are probably not relevant in that age group.
Go ahead.
I think I was going to say, for all older non-ambulatory boys, men, I think it's okay to ask the physician, say, hey, are you comfortable treating me? Do you have the required resources and expertise and experience here to safely treat me or treat my son? And then make the decision there. I think the safety is the paramount here, and also the goal in terms of what's our long-term goal from this therapy, to discuss the safety versus the benefits and the risks.
That's a really great point, Dr. Panda. Thank you. All right, young gentleman in the green.
My name is Jordan, and I'm 15, and I've been on Viltepso for 7 years, and I was wondering if gene therapy would be a good mixture with it.
Hey, Jordan.
I love that question. That's a huge question. We have so many individuals who are on steroids, exon skipping, and now are thinking about this. So thank you for bringing that up, Jordan. Who wants to take that?
I mean, if I don't know I think if you're eligible, or if you don't have things that would prevent you from getting gene therapy, I think you would be a good candidate for gene therapy. Now, the sequencing, like when would you stop your Viltepso, get the gene therapy, or you be able to go back on Viltepso? It's a conversation that you would have with your doctor, right? But I think, but yes, you would be a good candidate to get the therapy for gene therapy.
Thank you.
Thank you. All right, over here.
Hi, Rachel. I'm Tyler Connor's dad. I apologize for the 6,000 emails I've sent you in the last 2 months, but thank you. So Connor, we have he turns 1 on Sunday, and we found out his diagnosis about 2 months ago. So we are, again, the itty-bitty category, and so some of the challenges, I'll say, we've seen are a lot of the clinical trials require ambulation, and I assume that's to measure effectiveness as they can walk, maybe not. But my question is, with all the newborn screening, one day, hopefully, there's treatment right at birth. And my question is, what are the challenges or the methods to evaluate the effectiveness in treatments for kiddos that early?
So we've examined this. There are different companies looking at different modalities, gene transfer in particular, but in some other modalities as well, looking at very young patients. That data is not yet available because some of those studies have just gotten underway as young as 1 or 2 years old, and including the 3-year-olds. And so right now in those clinical trials, we're using a variety of different measures to try and assess efficacy or the potential benefits of those interventions. Some of those studies are going to include things like muscle biopsies to see if the muscles are changing in a way that we would hope that they would change. And so that data will hopefully eventually be able to be shared. In addition, we're looking at other more broad functional endpoints, like, for example, when they can walk, how fast are they walking? And we're using a variety of different measures to be able to try to capture that as accurately as possible. And then there are some other kind of developmental milestone markers and scales that are being used as well. So a common one used is one called the Bailey, but there are some others as well that can help to track the trajectory of our youngest kids. And we know that our guys with Duchenne tend to be within maybe the later end of some of those developmentally typical accomplishments. And so it will be interesting to see if maybe we can move them up to maybe the middle or even some of the earlier ranges, because all of those accomplishments with regard to motor function, they have a broad range. And so I think time will be able to help us answer those questions, but it is incredibly important that we start looking at our littlest ones like yours.
Yeah, Diana.
There are clinical trials. I think Disruptors, but two and older, 2 to 4, and I know RegenXBio just announced also going down to as young as 1 year old. So I think there are clinical trials in the age group, especially if you're looking at gene transfer therapy trials. And like Dr. Proud said, there are alternative ways to measure the outcomes.
Yeah, so not to be redundant, yeah, I mean, the ability to include them and measure outcomes and development when you know that you are also on an upward, there are incremental gains just by virtue of the motor development that's occurring. So you have that in the background of also, having Duchenne. So it is more of a moving target. But with that being said, we have, again, the outcomes and ability to track these children, even from the younger ages, even from infancy. I think newborn screening will at least potentially allow for being able to better identify these younger ones, to be able to think about how we're looking at them, measuring progression and development. I think for gene transfer, I think one caveat or consideration is, is there a point that's too early in terms of thinking about also the early muscle development and growth that's occurring? So that is just one consideration in terms of a lower limit. But you could envision perhaps if there are, some of these therapies even that are available now or in future development, some that are in trials that are, stabilizing the muscle via different pathways, whether it's steroid or non-steroid based pathways, could something like that be used early? So again, I think the potential is there, and that certainly, I think, probably should be a next aim.
Well, and Tyler, I almost wish I could, stake claim to planting that question because it was so well positioned. But the next session is all about outcome measures, especially some of the newer outcome measures that are currently being developed and validated that are going to go beyond things like the North Star and the 6-minute and the 10 and the 100 meter. So I think that you should stick around for that session, and it's going to be really helpful. I do want to be mindful of time, so I think we can maybe take 1 or 2 more questions, and then we'll have to start to wrap. But let's go over here.
Yeah, hi, I'm June from Katy, Texas. My question is, well, my son was just diagnosed as DMD just last week.
Oh my goodness.
I haven't yet visited a physician yet, but I'm just wondering, what's the thought process of selecting a medication for a patient? So, for example, well, my son is 2 years old right now, but let's say he's 4 years old and he's eligible for Exondys or Elevidys or whatever medications that he could take. Let's say you're accepting a new patient. What's the thought process of deciding which medication you want to prescribe? Thank you.
All right, I'll go. I think the first thing I would, like I was saying before, one baseline, I always talk about steroids. I think that's the simple, so first thing to talk about, put them on steroids. Discuss the pros and cons, the different dosing regimens if you want to talk about daily versus and all of that. And then when it comes down to if your boy is eligible for both exon skipping versus gene transfer therapy, I think we have to, we'll discuss both pros and cons again. And if I have to recommend, I would probably recommend a gene transfer therapy first before you think about an exon skipping agent later on. Several reasons. One of the main reasons would be definitely the payers, because once you get an exon skipping agent, then then we don't know if they're going to pay for gene transfer therapy. So maybe get that first, and then think about adding on therapies depending on how he does, and having this discussion with your neurologist will be helpful. But this is how I approach.
Awesome. All right, let's do one last question and then we'll start to wrap.
So yes, I think you have answered half of my question already. So the question is related again to the Jordan. Like, if our sons are already on exon skipping and the insurance or the Medicaid, they approve for gene therapy also, will they able to take it together, or do they have to stop exon skipping, wash out, and then take gene therapy? Because both are commercially approved now, it's not in the clinical trial. So what will be the procedure to have both the drugs together?
So in the clinical trial programs, we did not continue the exon skipping at the same time as we gave the gene transfer. However, we did have many boys who took exon skipping immediately up until the point where they received gene transfer, some as early as 1 day prior to administration of gene transfer. This did not demonstrate any change in risk for adverse effects, and so we did not see any difference there. But we did not do it concomitantly, meaning at the same time as gene transfer. So there is still the open question of the potential benefit for additional exon skipping after gene transfer, and I think this is something that all of us are very interested in understanding and learning more about, but we don't yet have data on that. I personally don't necessarily think that there is a likelihood for a major adverse effect, but it's a risk that would have to be discussed, knowing that we don't have data on that, and your risk tolerance as a family for whether you could tolerate the potential for a risk, but also knowing that we don't have clear data on benefit. And so once again, an individual discussion, I think, with the clinician.
You may hear another group, thought process, like, maybe you have to give some time for your gene transfer and kind of deal with the safety from that, get over that period of 3 to 6 months before you start back again, the exon skipping agent. That's still a good approach, because sometimes when you get something, God forbid, there's something happens, it's really hard, they're just not known to be associated with either one of those drugs, then it's hard to say which one is causing what. So I think it's always safe to wait, give that period of few months at least before you start. So you're going to have different opinion from different physicians based on their comfort level. I think you have to have that individual discussion.
Right.
Awesome. Thank you
so much. Thank you.
Wonderful. Okay. I am a little bit over, but I want to do our closing question that I know that I shared with most of you as we were preparing for today's panel. But it comes down to, like, what does this mean for me? What can I take away from this session? Because each individual is just that. He or she is an individual with a specific plan of care. So the question is, if you want families in the room today to take away one critical question for their neuromuscular team when they get home, or one thing to keep in mind pertaining to newly approved therapies, what would it be? We'll start with Dr. Clemens at the end and work our way down, and then we'll be done.
So I think my takeaway would be is there are no absolutely right or absolutely wrong answers, and with many options, then obviously the discussion becomes longer, and you can think about it. But I would think about it with your professional, with your healthcare professional. But I would also not be too hard on yourself, because this is a complex environment, and there really isn't any wrong answer to what you choose for your child or yourself.
I would say, again, just make sure these discussions are happening. Ask your clinicians, ask your teams, really review. I said before, really thinking about that risk and benefit. Really think about that at any point. And again, know that these discussions can really happen over time. And know that there's also more evolving in the research landscape. So it's a dynamic field, but just keep having frequent discussions with your team in that shared decision making.
So I'm going to have three things. So one, I think this is an exciting opportunity with all these approved therapies. There is a lot of opportunity for us to learn about the add-on and the combination therapies as we go on. I think if you could contribute to that learning by participating in trials or registries, I think that would be great. Number two, we talked about all of these therapies and exciting times, but we have to keep in mind there are still a lot of families out there who have difficulties in accessing just basic care. So there are friends and families, friends of yours, and in neighbors or could be in other states. Please do talk to them and encourage them talk to them about this, and let's get all boys who deserve the best care for them. There's a lot of challenges in accessing care. If you go down to some of the rural states, I think it's important to keep that in mind. And again, same thing kind of applies to it's United States, but think about other countries where there's not even have access to standard of care. How can we help push that forward?
Dr. Proud?
So I agree with everything that's been said, and I would just add to discuss, as you're thinking about these new and exciting opportunities, really taking a moment to think about, is there something I'm going to choose now that may impact my opportunities or the opportunities for my child in the future, in the very near future? Obviously, it will impact their long-term future. But if I make a decision today, is there the potential for it to prevent me from another opportunity that I might find intriguing or potentially helpful, whether that be a commercially available therapy or potential participation in a research clinical trial? And so perhaps not jumping into that decision making and really thinking about how your choice today may impact the next 3 or 6 months or a year. And some of these therapies have the opportunity for us to be able to make that decision a little bit slower than maybe one might anticipate. So for example, even gene transfer therapy, it is okay to have that decision or that therapeutic infusion take several months or even a year before it occurs. We would still expect to see benefit with that. And so order of operations is something worth considering and making sure that you feel confident and safe in your decision.
Wonderful. Dr. Abdul, Hamid, you get the last word.
I agree. I think our work is yet to begun. This is just the beginning. I remember when I first started becoming interested in this disease space, I signed up for all the emails, and we would get emails saying, this new therapy cured the rat and mice, and then it would go into human development and fail, and then times that by 10, and then you unsubscribe from those emails and you start to lose hope. And now that we have all these 8 newly approved treatments, our hope is reignited and reinvigorated. So I would just go home and continue to fight the good fight. We're going to fight the insurance companies. We haven't forgotten about the patients that are left behind, the 8 and 9 deletions. We haven't forgotten about boys who have antibodies. We haven't forgotten about the girls and the female carriers and the Becker patients. So we're just going to have to keep fighting, and our work has just started.
Hold on to hope and fight for every future. Oh my goodness. Thank you to our panelists. You all did a wonderful job. I learned so much from each of you. We're just really lucky as a community to have folks like you fighting for us each and every day. I ate into your break, I'm so sorry. So you all get a break until 4:20, and then when you come back, it will be the Eras Tour of Outcome Measures. Yes, it is a Taylor Swift little nod. So go take a few minutes. We'll see you back at 4:20. All right, thank you.